Hi guys, good evening. So this session is dedicated for trauma and neurosurgery. So the topics that we are going to discuss, because I've already discussed half of it in our general surgery where we're talking about the primary assessment, we spoke about shock, so everything is covered there. So predominantly I'll be talking about the neurotrauma and the thoracic trauma. That's our exam question that has been asked, right? So what are the questions that they asked? The question number one, they've asked you a short note on the Glasgow coma scale. They've asked you about the extradural hemorrhage, that is EDH. They've asked you about the STH, that is your subdural hemorrhage as well. And they've asked you on Cushing strat. So all these are short questions that they've asked you. In thorax, they've asked you about flail chest. And they've asked you about traumatic pneumothorax. Right? All these are small questions which are there, so we'll try to cover all of them. That is your GCS, your EDH, your SDH, Cushing strat, flail chest and everything. So we'll start with the first one, that is going to be our Glasgow coma scale. Okay? So let's talk about the GCS scoring system or the Glasgow coma scale. I hope everybody should be able to know this. This is a non-negotiable point that you should understand and remember GCS scoring system. So I'll be talking about the Glasgow coma scale. Now, when you talk about the Glasgow coma scale, it consists of three parameters. That is your eye opening, verbal response, and motor response. It is called EVM. It is E4, V5, M6. That is the maximum score that is given. So when you look at the representation, the first one is going to be about the eye opening. Number two is the verbal response. And number three is the motor response. So we'll be considering all three of them. That is your eye opening, the verbal response, and the motor response. Now, how do you do an assessment for these responses? The eye opening, if it is spontaneous. If it is spontaneous, a score of 4 is given. That means you don't need to do anything. Thank you, Santosh sir. I mean, like one consistent audience that I have in all my lectures, no, irrespective of who it is our Santosh sir. Right? Thank you so much for the support, sir. Right, so when you talk about eye opening, if it is spontaneous, it is going to give a score of 4. If the patient is not opening spontaneously, you go call out his name. If he is opening to speech, a score of 3 is there. If there is not even opening to speech, then I am going to stimulate the patient. The stimulate is painful stimulus. So next is going to be stimulus, which is going to be a painful stimulus, a score of 2. And if there is no response, if there is no response for eye opening, a score of 1, we never give a score of 0 on GCS, right? So the eye opening can be easily remembered. It all starts with S only, spontaneous to speech and to a stimulus, that is painful stimulus. This is how you'll remember it. Now, when you talk about the verbal response, in the verbal response, when you're talking to the patient is oriented. Now, when I say oriented, the orientation is to time, place, and person. If he is oriented to time, if he is oriented to place, and if he is oriented to person, if the orientation is there for time, place, and person, if the orientation is there for time, place, and person, a score of 5 is given. That means if he is able to recognize what time of the day it is it going to be, is it in the morning, afternoon, evening, or night? If he is able to recognize that, if he understand he is in a hospital casualty and the person who brought him is a known or unknown person, if he is able to recognize, we say orientation is there, a score of 5. On the other hand, if the patient is confused, he's thinking he is in Taj Mahal, the person who brought is not his wife but a maid or a servant or a slave, it is a problem that you need to understand. The patient is confused. If the patient starts abusing you, gives you an inappropriate response, inappropriate words, If the patient is using inappropriate words, a score of 3. If you ever have doubt in inappropriate spelling, you have 3 P's, and that's how you remember it is 3, right? So that's your inappropriate words, right? Then if the patient is trying to talk, but you're not able to make any sense out of it, it's like, Tushar Kapoor of Golmaal, where and is going on, and not able to make any sense out of it. So if it is incomprehensible sounds, if there is incomprehensible sounds, if there is an incomprehensible sounds, a score of 2, and if the patient is on mute, that is no response. If the patient is on mute, that is no response, a score of 1 is given. Then we are going to go with motor assessment. Now in the motor assessment, if the patient obeys command, that is touch nose, touch feet and everything, if everything is motor responses there, we call it a score of 6 is given if he is obeying command, right? Now if he moves to a localized pain, he is able to localize where the pain is there. If he is able to move to a localized pain, a score of 5 is given. If there is flexion withdrawal to pain, if there is flexion withdrawal to the pain, a score of 4. If there is a decorticate rigidity, a score of 3. If there is a decerebrate rigidity, a score of 2. And if there is no response, a score of 1 is given. So a patient obeys command, moves to a localized pain, flexion withdrawal of the pain, there is decorticate, So when you talk about decorticate and decerebrate rigidity, just for the sake of understanding, decorticate is what we call it as the flexion rigidity. It is the flexion rigidity. Decerebrate is your extension rigidity. It is an extension rigidity. So now decorticate rigidity, that is in flexion rigidity, you see the patient is completely flexed. In a decerebrate rigidity, the patient is lying down as if he does not care what's happening in the world. So these are extension rigidity. It's an extension rigidity, right? So this is about your decorticate and decerebrate rigidity. Now, once you have written about the Glasgow Coma Scale, they'll expect you to tell the following components. Number 1, what is the maximum GCS score that is there is going to be a score of 15 by 15. You should also tell what is the minimum score possible. The minimum GCS score that is possible is going to be 3 by 15. Now, this is a good time where you say there's a new score called as a GCS-P score. So now GCS-P score, P is your pupillary assessment score. It is your pupillary assessment score. So now pupillary assessment score, if both the pupils are reactive to light, both pupils reactive to light, score of 0 is given. If one pupil not reactive to light, if one pupil not reactive to light, a score of -1 is given. If both the pupils are not reactive to light, both pupils not reactive to light, a score of -2 would be given. A score of -2 would be given. So when you add up a GCS-P score, so in a GCS-P score, the GCS score is 15, that is your maximum, plus P score maximum is going to be 0. So the maximum GCS-P score still remains 15. When I say what is the minimum GCS-P score, the minimum is 3 and the minimum here of P is -2. So it is going to be 1. So the minimum GCS-P score, is going to be 1 whereas maximum still remains as 15. Now When a patient has risk for coma, the patient is going to have risk for coma if the GCS is less than or equal to 8/15. And when would you go ahead with prophylactic intubation? Now, prophylactic intubation is also required when the GCS score falls less than or equal to 8/15. So this is your GCS scoring, right? So our first question was on GCS, a short note. This is for 3 marks, and this is more than enough about the GCS. Next, we go over the EDH and SDH. We talk about the traumatic head injuries. So the next answer we're going to talk about is going to be your traumatic head injury. So we talk about the traumatic head injuries. Now we classify the traumatic head injuries into 2 categories. One is going to be the primary head injury. One is the primary head injury. Another one is your secondary head injury. Another one is your secondary head injury. So one is your primary head injury, another one is your secondary head injury. So when you look at the difference, primary head injury is injury to the brain. It is injury to the brain due to impact from trauma. Due to impact from trauma. Secondary head injury, it is going to be injury to the brain. It is injury to the brain due to increased intracranial pressure as a result or sequelae of primary brain injury. Of the primary brain injury. In simple words, whenever there's a primary brain injury, there is brain injury or there is brain damage. Some tissue erosion or injury is there. That will cause inflammation. Inflammation will cause edema, and that edema will further increase, right? That edema will further increase the intracranial pressure, causing more deterioration in the brain injury, and that is what we call a secondary brain injury. That is injury to the brain due to raised intracranial pressure as a result or a sequelae of your primary brain injury that is present. So we talk about the primary brain injury or the primary head injury that we're talking about. In the primary brain injury, rather than saying head injury, we'll say primary brain injury. So talking about head will also increase skull, no? So primary brain injuries. So the head is now being replaced by brain. Talking about the primary brain injury. Okay, so when you talk about the primary brain injuries, we have 3 varieties that I can give you an objective here. One, it is concussion injury. Another one is diffuse axonal injury. Diffuse axonal injury and the intracranial hemorrhage. So you have the concussion injury, diffuse axonal injury, and the intracranial hemorrhage. Now, concussion injury, here the patient will have transient, that is temporary. There is a transient state. There is a transient state of confusion. There is no structural damage. Now, because there is no structural damage, it is usually a reversible injury. It's a reversible injury. And when you get an NCCT done here, In these patients, it remains normal. There are no findings that you will see. So here it is only going to be a supportive care. So nothing to be done here, just provide supportive care to the patient. Diffuse axonal injury is described as a complete disruption. There is complete disruption of axons between white and gray matter. Between white and gray matter. Now, because of that, the patient lands up into coma. So post-traumatic coma is seen. Now, as soon as the patient comes to you with head injury with coma, obviously I'll get an NCCT of the brain. Now, NCCT here also appears to be normal, so that gives you a high suspicion. So get an MRI done. An MRI, there will be presence of punctate hemorrhage. Presence of punctate hemorrhage between white and gray matter. Between white and gray matter. Now, diffuse axonal injury, it is associated with very poor prognosis. This is associated with very poor prognosis. Now, when it comes down to the intracranial hemorrhage, this is what your examiners are usually interested about. So, we'll talk about the intracranial hemorrhage. So, talk about the intracranial hemorrhage. Let's go from inside out. Let's say this happens to be the brain parenchyma. Surrounding the brain parenchyma, which is present immediately next to it, it is what we call as the pia mater. In fact, the pia mater is inseparable from the brain. The pia mater is inseparable from the brain. After the pia mater, you have the arachnoid membrane, and this happens to be your arachnoid membrane. Surrounding the arachnoid membrane, you have the dura as well. Surrounding the arachnoid membrane, you have the dura which is present. So dura is the outermost layer that you will see here. And then surrounding the dura, you have the skull bone. So this is the representation of the skull bone. Look at this is the representation of the skull bone that is present here. So this is the representation of the skull bone that you have. So when you go from inside out, this is the outermost, which is going to be the skull bone. Then you have the dura. Then you have the arachnoid membrane. And then you have the pia mater. Now, right in the center, that is in the subarachnoid space, you have this fluid which is freely floating. And the fluid that is present between the pia mater and the arachnoid membrane is what we call it as the CSF fluid. This is what we call it as the CSF fluid, that is a cerebrospinal fluid. So CSF is present in the subarachnoid space. The CSF is present in the subarachnoid space. And this is obviously, when you look at the spinal cord, this is where the cord is going to extend. So this is also having the same component. You'll see, you'll have the dura, you have the arachnoid membrane, and you see the CSF flowing there also. Right now, this is your cerebrospinal fluid. Now, if the bleeding occurs within the brain parenchyma, it is called as intraparenchymal hemorrhage. This is what we call it as the intraparenchymal hemorrhage. Now, if the bleeding occurs here, this is what we call it as the subarachnoid hemorrhage, called as SAH. that is a subarachnoid hemorrhage. This is your subarachnoid hemorrhage. Then you have this, which is under the dura, which is your subdural hemorrhage, which is called as the SDH. SDH is your subdural hemorrhage. And the last one that you have is the most dramatic one, which is here, outside the dura, in between the skull bone. This is what we called as the EDH. EDH is your extradural hemorrhage. EDH is your extradural hemorrhage, right? So this diagram is very important, where it tells you that you have known all the different sites of the hemorrhage, from the intraparenchymal to the subarachnoid to the subdural to the extradural hemorrhage, right? So this is the basis of what we should be aware of in terms of the cranial hemorrhages. Now they've asked you to write a short note on the SDH and EDH. So we'll have a comparison between these two, that is the difference between an EDH and the SDH. So EDH is your extradural hemorrhage. EDH is your extradural hemorrhage. SDH is going to be your subdural hemorrhage. So the extradural hemorrhage and the subdural hemorrhage. So the EDH and the SDH. We have the EDH and the guys will take the doubts at the end, right? So we have the EDH and the SDH, that is extradural hemorrhage, and the subdural hemorrhage. The first one is going to be the definition. So talk about definition. Remember EDH, it is defined as the collection of blood. It is defined as the collection of blood between the dura and the skull bone. Between the dura and the skull bone, which we have just learned about it. What is an SDH? SDH is defined as the collection of blood. It is the collection of blood between the dura and the arachnoid membrane. So why does these occur? So what are the mode of injury? So you should know what is the mode of injury in both of them. So talk about the mode of injury for an extradural hemorrhage. It is usually associated whenever there is temporal fracture. Now, temporal fracture, where you have the three bony prominence, which is it's called a sterion, which is the weakest point. If it gets injured, usually the hit or blow to the temporal region or temporal fractures, they are associated with extradural hemorrhage. SDH, it is significant if there is a significant history of hit, blow, or fall overhead. This is what leads to subdural hemorrhage. Next comes, what is the source of hemorrhage? So where is source of bleeding in these two? What is the source of bleeding? What is the source of bleeding that you will see here? For extradural hemorrhage, it is because of injury to the middle meningeal artery. It is due to the injury to the middle meningeal artery. Here it usually from a cortical bridging veins. It is usually because of cortical bridging veins, right? Now, if you look at both, we'll just, because I'm creating as a tabular column, we'll just enclose it in the same context. Now, when you talk about the clinical features, can you all see me? Some glitch here. I hope everybody's clear. Okay, fine. Continuing our discussion on the same context. Okay, the source of bleeding for the extradural hemorrhage is going to be middle meningeal artery. For the subdural hemorrhage, it is going to be cortical bridging vein. So let's see how will they present to you in terms of clinical features. In terms of clinical features. See, in both of them, because as it bleeds, it is going to occupy a lot of space. So if you talk about the clinical features here, just for the sake of understanding, we just spoke the outermost layer that we have is the skull, which is present here. Just under the skull, you have the dura, which is present. So there is this dural adhesions which are going to be present with the skull bone. So dura is not a free space. There are some adhesions with the skull which is going to be present. So this is the dura which is present. Below the dura, I have the arachnoid membrane. Below the arachnoid membrane, I have the pia mater. And below the pia mater, I have the brain parenchyma. Just for the sake of understanding, let's say this is the brain parenchyma that you have. Right? Now, whenever the injury is going to occur, that is in terms of the extradural hemorrhage, I see the blood will start collecting here. Now, as the bleeding continues to happen, more and more amount of blood will come. So it will start occupying this entire space. Because there's a bridge here, it cannot go past here. And because an arterial bleed, it will occur very fast. Now, as it is occurring very fast, this area is going to fill up. Now, what the bleeding is continuously happening. Now, skull bone is rigid. It cannot be budged. It cannot be pushed back. So you will see that all that blood is going to get accumulated, will accumulate in this particular fashion. Now, as it accumulates in this particular fashion, it is pushing the dura downwards. But more importantly, it is causing pressure over the brain parenchyma. You see, this is the dura which is present. So, which is obviously remains continuous. It is exerting pressure on the arachnoid membrane, which is here. Obviously, the pia mater is also getting compressed. You see, the entire force of this bleeding is now going to fall across here. Now, obviously, when it is exerting pressure, it will exert pressure onto the brain parenchyma. And you will notice that it is now going to cause the parenchymal pressure. And that increase in the brain parenchymal pressure is now going to become symptomatic. So in an extradural hemorrhage, as there is significant amount of bleed that is getting accumulated between the skull bone and the dura, it exerts entire pressure onto the surface of the brain, or I can say the brain parenchyma, hence becoming symptomatic. So the clinical presentation for an extradural hemorrhage, patient will have signs and symptoms of increased intracranial pressure, but these will occur sudden and severe in onset. All the symptoms will be sudden and severe in onset. Right? So what are the symptoms that you will see? As soon as it is going to occur, the patient is going to have, obviously, post-traumatic. The patient will have headache. Now, head injuries, whenever they usually present to you with vomiting, not with nausea, and this is what we call as projectile vomiting. It's a classical feature of head injury that is present. So, there's nausea, vomiting is there. There'll be blurring of vision. There'll be blurring of vision. There'll be post-traumatic seizure. So, headache, vomiting, blurring of vision, post-traumatic seizure are the common complaints that you will see. But along with that, you will see a very, very important finding in extradural hemorrhage, which is called as presence of lucid interval. Now, the concept of lucid interval, it is defined as the period of consciousness. It is the period of consciousness between two unconscious episodes. Between two unconscious episodes. So what happens is, initially when the bleed occurs, it is going to occupy and is going to cause sudden increase in pressure. Patient becomes unconscious. Now, once that hematoma which is formed is going to exert pressure on the middle meningeal artery from where the bleeding is occurring, it stops the bleed from there. It is called as tamponade effect. Once the bleeding stops, patient regains consciousness. Patient starts to move around. When a patient starts to move around, obviously the clot can dislodge. Dislodging of the clot will cause rebleed, again increase pressure, again become unconscious. So period of consciousness between two unconscious episodes is what we call as lucid interval, and it is characteristic. It is absolute characteristic of an extradural hemorrhage. It is an absolute characteristic of the extradural hemorrhage, right? Now, when you talk about it in terms of, sorry, subdural hemorrhage. Now, subdural hemorrhage will also have, they will also have the signs and symptoms of increased intracranial pressure, but this time patient will have gradually progressive symptoms. Patient will have gradually progressive symptoms. Everything remains the same. If I just replicate it, this is the skull bone that you have. Next to it, you have the dura, which is going to be present here. As I told you, the dura will have these communication, but this is not relevant for this part of discussion. This is your arachnoid membrane that is present here. And then under this, you have your pia mater, and under the pia mater, you have your brain parenchyma, which is here. So this is the brain parenchyma that we have. So this is the brain parenchyma that you have. On the other hand, so when the bleeding is going to occur, where would the bleed occur? Now, bleed is going to occur here. Now, because it's a venous bleed and because there is no barrier, it will continue to occupy this space. So, until unless it is not occupying the entire component, it will not cause symptom. तो extradural और subdural hemorrhage के बीच का फर्क ये है कि EDH में आर्टरी से ब्लीड कर रहा है तो ज़्यादा ब्लीड करेगा, जल्दी ब्लीड करेगा, एंड इट विल हैव मोर वॉल्यूम, मोर प्रेशर और सडन इंक्रीज होगा. सब ड्यूरल हैमरेज में वीनस ब्लीड है, धीरे धीरे करके ऊज करेगा, धीरे धीरे ब्लड सेटल नहीं होगा, यहाँ पे कोई बैरियर नहीं है, पूरा पैरेन्काइमा मैंने पूरा सरफेस अवेलेबल है, तो धीरे धीरे फिल इन करेगा, एंड वंस इट फिल्स अप कंप्लीटली देन इट इज गोइंग टू कॉज प्रेशर. ठीक है, तो ऑब्वियसली हमारा एक्सटर्नल हैमरेज इज मोर सीवियर व्हेन कंपेयर्ड टू सब ड्यूरल हैमरेज. दैट इज द फर्स्ट थिंग दैट वी नीड टू अंडरस्टैंड. अब यहाँ पे आप ब्लीड का देखो तो ब्लीड इज अकरिंग इन दिस पर्टिकुलर फैशन. तो ब्रेन पैरेन्काइमा में इतनी जल्दी प्रेशर क्रिएट नहीं करता, ग्रेजुअली क्रिएट करता. जो ग्रेजुअली प्रेशर बढ़ेगा तो ऑब्वियसली क्या सिम्टम्स पेशेंट हमारे पास लेके आएगा. Here the patient will have again headache होगा. Patient will also be associated with vomiting. Along with that, the patient will also complain about blurring of vision. Usually traumatic seizures नहीं होते. Seizures are in sudden increase in pressure. Here you will see ipsilateral pupil dilation. Same sided pupillary dilation मिलेगा. Contralateral, opposite side, you will see weakness, that is hemiparesis, right? So ipsilateral pupillary dilation with contralateral hemiparesis is what you will see in an subdural hemorrhage. It's a subdural hemorrhage, right? Clear? So when a patient presents to you with these features post-trauma, I would like to investigate in terms of investigation. Traumatic head injury में you should only perform NCCT of the head. तो दोनों जगह आप सिर्फ NCCT करोगे. NCCT में what are the findings that you're going to find? So just to understand, again I don't want to go into greater details. I don't want to give you an extra burden, but just for the sake of understanding, this is how the brain is described. So this is your flax cerebri, this is the tentorium, this is the cerebellum, and this is the brainstem. Okay, same here. Now same context which you have done here. So you will have the pia mater which remains inseparable. So this is the pia mater which is present all across. Surrounding pia mater you have the arachnoid membrane. तो ये आपका arachnoid membrane है. So it is consistent like this. Surrounding the arachnoid membrane you have the dura, and this is the dura that we have. Surrounding the dura you have the skull bone. तो ये आपका skull bone हो गया. This is the skull bone that is present here, right? Ramesh, we have covered almost all the topics which are important for our exam. So एक बार आराम से बैठ के पढ़ लेना. You will be able to go through it well again. ठीक है? चलो. So let's see the findings that you're going to see. Right in the center, you will see the ventricles are present. So these are going to be the ventricles. These are the ventricles which are present here. So when the bleeding is going to occur, we talk about the extradural hemorrhage. The bleed will occur here, and this is how the bleed will take place. ठीक है, तो ये space हो गया आपका extradural hemorrhage का. On the other hand, this is how your subdural hemorrhage would look like. ठीक है, this is the difference between EDH and STH. So what are the findings that you can see? The first thing you can see that it is giving you an opacity which is of that shape. The one surface is it's a convex surface, the other one is also convex. So this is what we call it as the biconvex opacity. This is what is biconvex opacity. दोनों surface इसके convex है, ये भी convex है, ये भी convex है. ठीक है, so biconvex opacity is noticed. इसी को आप lenticular opacity भी बोलते हो. ये आपका lenticular opacity भी हो गया. प्रेशर बढ़ेगा, इट इज गोइंग टू एक्सर्ट प्रेशर ऑन टू द ब्रेन पैरेन्काइमा, जिसकी वजह से आप देखोगे आपका फ्लैक्स सेरेब्रा जो सेंटर में है, इट इज गोइंग टू डिविएट, एंड दिस डिविएशन ऑफ द फ्लैक्स सेरेब्राई इज व्हाट वी कॉल इट एज द मिड लाइन शिफ्ट. इट इज व्हाट वी कॉल एज मिड लाइन शिफ्ट. ज़्यादा प्रेशर हो जाएगा तो आपका जो सेरिबेलम है, right? So this is the cerebellum, this is the cerebrum. That's your brain parenchyma, and this is cerebellum. You will notice that this brain parenchyma is going to herniate via the tentorial space. It is going to go down, and this is what we call it as the transtentorial. This is a transtentorial herniation. It's a transtentorial herniation is going to happen. So these are the findings on the NCCT. Whereas when we talk about in the subdural hemorrhage में क्या findings देखने को मिलेंगे? Subdural hemorrhage में आप देखो एक surface आपका convex है, एक और surface आपका concave है, तो एक ऐसे है और एक ऐसे है, right? One is concave, another one is convex. So this is what we call it as concavo-convex opacity. This is your concavo-convex opacity. Again, they will exert pressure. The possibility here is again of, this can also be called as a crescent opacity. Now today is actually the crescent day, so everybody happy Ramzan starting from today, I guess. So this is how the moon is going to look like, and in our medical terms we can say it is how your subdural hemorrhage is going to look like, right? So crescent opacity is there. So concavo-convex opacity, then you have the crescent opacity that is present. This can also be associated with the midline shift. So this is where you can see the flux cerebri is going to move across here. This is what we call as a midline shift, right? Now, how do you manage? So when you talk about the management, in emergency, I can do a burr hole surgery. So see, we say emergency burr hole is done only when CT is not available. When CT is not available and patient is deteriorating fast, that is when you do burr hole surgery. But if I say what is a definitive surgery? The definitive surgery is going to be craniotomy and identify the site of the bleed and control. Now, there's a very poor misconcept that a lot of students have कि sir mannitol शुरू कर देते हैं head injury में. But a mannitol should not be given in extradural hemorrhage क्योंकि mannitol क्या करता है? It is hygroscopic. It draws the water out. तो वो cerebral edema कम करता है. अब देखो अगर extradural hemorrhage में एक तो bleed हो रहा है, ठीक है? अब आपने मैनिटॉल दे दिया, मैनिटॉल क्या करेगा? ब्रेन में से पानी खींच लेगा, तो ब्रेन और श्रिंक करेगा. अगर ब्रेन श्रिंक करेगा तो ऑब्वियसली आप हेमेटोमा का एक्सपैंड होने का ज्यादा स्पेस दे रहे हो ना, तो हेमेटोमा और एक्सपैंड होगा, और जितना ज्यादा एक्सपैंड होगा उतना ज्यादा प्रेशर क्रिएट करेगा. मुझे हेमेटोमा एक्सपैंड नहीं होने देना ना, तो अगर आप मैनिटॉल दोगे इट क्रिएट्स मोर स्पेस फॉर द हेमेटोमा टू एक्सपैंड, इट वर्सन्स द सिचुएशन. तो एक्स्ट्रा ड्यूरल हैमरेज में मैनिटॉल नहीं दोगे. सब ड्यूरल हैमरेज में व्हेन यू हैव अ पेशेंट विद एसडीएच, अगर स्मॉल एसडीएच है, स्मॉल सबड्यूरल हैमरेज है, आई विल स्टार्ट द पेशेंट ऑन मैनिटॉल, ठीक है, ताकि एडिमा कम करे, प्रेशर कम करे, एंड देन विल कीप इट ऑन कंजर्वेटिव मैनेजमेंट, then we keep it on conservative management. Achha, if there is a large STH which is creating symptoms, now itna yaad rakhna, whenever there is a large STH, that is subdural hemorrhage, to drain this I would like to do a burr hole surgery, ठीक है. अब ये large STH, if it is a chronic STH, large STH is chronic, chronic STH का मतलब होता है subdural hemorrhage is persisting beyond more than 21 days, उसके लिए बरहोल करोगे. लेकिन अगर एक्यूट लार्ज एसटीएच, एक्यूट लार्ज एसटीएच के लिए आप क्रेनियोटमी करोगे, ठीक है. सो फॉर द क्रॉनिक लार्ज एसटीएच दैट इज मोर देन 21 डेज, इसके लिए बरहोल करोगे, अदरवाइज विल गो अहेड विद क्रेनियोटमी. दैट्स द बेसिक कंपोनेंट दैट यू नीड टू अंडरस्टैंड विद रिस्पेक्ट टू योर हेड इंजरीज, ठीक है. तो हमारे बाकी दो टॉपिक्स भी खत्म हो गए हेड इंजरी के जो हमने बात किए थे. So we have completed your EDH as well as STH, ठीक है. चलो, so this is with respect to your EDH and STH. फिर आती है Cushing's triad. They've asked you the question on Cushing's triad. So basically Cushing's triad जो है, it is seen in increased intracranial pressure. Cushing's triad is seen in increased intracranial pressure. It could be of any reason. Cushing's triad के तीन components क्या क्या हैं? Number one, you will notice in Cushing's triad that it will be associated with hypertension, bradycardia, and irregular respiratory rate. There's an irregular respiratory rate. So hypertension, bradycardia with irregular respiratory rate is what we call as Cushing's triad. Let's understand why does it happen so. तो Cushing's triad ना raised ICT में होता है, तो we need to understand a basic concept behind it. That is something called as the cerebral perfusion pressure. Now the cerebral perfusion pressure is what we call it as CPP. How do we calculate it? It is calculated as the mean arterial pressure minus intracranial pressure. We all know the mean arterial pressure is a combination of 1/3 systolic blood pressure and 2/3 of your diastolic blood pressure, okay, with that of the intracranial pressure. So normally when we say the mean arterial pressure, which is considered normal, is going to be 90 to 110 millimeters of mercury, is what we have a normal mean arterial pressure. And normal intracranial pressure is going to be 5 to 15 millimeters of mercury. By that logic, the normal CPP is going to come as 75. It will come as 75 to 105 millimeters of mercury. This is the normal cerebral perfusion pressure which is there. That means this is the pressure that you require for a patient to perfuse the brain. As simple as that. Now, what is happening in a patient who's having a brain injury? I will calculate the cerebral perfusion pressure as the mean arterial pressure minus intracranial pressure. So, अभी brain injury हुआ है, इंजरी में क्या होगा, इंट्राक्रेनियल प्रेशर इंक्रीज करेगा, तो ऑब्वियसली हेमेटोमा इज गोइंग टू ऑक्यूपाई दैट स्पेस. जैसे हेमेटोमा ऑक्यूपाई करेगा उसकी वजह से इंट्राक्रेनियल प्रेशर बढ़ेगा. अगर इंट्राक्रेनियल प्रेशर बढ़ेगा तो सेरिब्रल परफ्यूजन प्रेशर फॉल करेगा. सिंपल सा इक्वेशन है, ठीक है. अब प्रॉब्लम ये है कि बॉडी बोलता है आई कैन नॉट लेट दिस हैपन, कि भाई अगर सीपीपी ड्रॉप कर गया, मुझे पता है कॉन्सेप्ट है, उसको बोलते हैं मिनिमम सीपीपी, ठीक है. सो रिमेंबर द मिनिमम CPP required to perfuse the brain. minimum CPP required to perfuse the brain, it is anywhere between 60 to 65 millimeters of mercury. इससे कम में ब्रेन का काम चलेगा ही नहीं, ठीक है। अगर सीपीपी इससे कम पे ड्रॉप हो जाता है फिर तो दिक्कत हो जाएगी, ठीक है। तो बॉडी बोलती है मैं तो उसको होने ही नहीं दूंगी। हमने बोला बॉडी क्या करेगी, बॉडी बोलती है एक काम करते हैं, मैं मीन आर्टीरियल प्रेशर बढ़ा देती हूँ जिसकी वजह से सीपीपी बढ़ जाएगा, तो इट विल न्यूट्रलाइज द इफेक्ट ऑफ योर रेज इंट्राक्रैनियल प्रेशर। सो बॉडी सेज इन ऑर्डर टू कॉम्पनसेट जो भी आपका प्रॉब्लम हो रहा है रेज आईसीटी की वजह से, इंट्राक्रैनियल प्रेशर बढ़ रहा है तो सीपीपी फॉल कर रहा है, मेरा मिनिमम होना चाहिए 60-65, इंट्राक्रैनियल प्रेशर बढ़ता जाएगा सीपीपी फॉल होता रहेगा। अगर सीपीपी फॉल्स बिलो 60, इसका मतलब है there will not be adequate pressure to perfuse the brain and neurons are the most sensitive, they are very sensitive, the most sensitive tissue to hypoxia, तो brain injury हो जाएगी और वो irreversible होती है। बॉडी बोलती है मैं थोड़ा मरने दूंगी, मैं I will come everything, I'll put everything I have and I'll put it on line to save the body basically। तो हमने बोला यार आइडिया तो अच्छा है लेकिन यार तू मीन आर्टेरियल प्रेशर बढ़ाएगा कैसा। उसने डिसाइड कर लिया कि हम ना मीन आर्टेरियल प्रेशर बढ़ाएंगे ताकि काम बन जाए। तो हमने बोला बढ़ाएगा कैसे, तो बॉडी बोलती है तो टेंशन मतलब मैं बताती हूँ। मैंने बोला बोल कैसे, तो बॉडी बोलती है एक काम करते हैं, देखो मीन आर्टेरियल प्रेशर को अगर आप कैलकुलेट करोगे तो मीन आर्टेरियल प्रेशर क्या है, ये आपका 1/3 सिस्टोलिक ब्लड प्रेशर है और 2/3 डायस्टोलिक ब्लड प्रेशर। इन दोनों में से अगर आप एब्सोल्यूट प्रेशर मानोगे वो तो सिस्टोलिक है, डायस्टोलिक है रिकॉइल प्रेशर। तो बॉडी बोलती है रिकॉइल प्रेशर को मार गोली, एक काम करते हैं सिस्टोलिक ब्लड प्रेशर बढ़ाते हैं। तो बॉडी डिसाइड्स टू इंक्रीज द सिस्टोलिक ब्लड प्रेशर। अब ये सिस्टोलिक ब्लड प्रेशर, तो ब्लड प्रेशर है क्या, it is the pressure exerted by the volume of the blood onto the lateral walls of the vessel and that is what we call as blood pressure। तो अगर आप definition देखोगे, it is the pressure exerted by the volume of the blood onto the lateral walls of the vessel। तो pressure is determined by two components, either the volume or the size of the lumen। तो बॉडी बोलती है एक काम करते हैं, देखो प्रेशर बढ़ाने के लिए दो चीज कर सकते हैं, या तो वॉल्यूम इंक्रीज कर लो या तो either you increase the blood volume into the vessel or you decrease the size of the lumen। अगर ल्यूमन का साइज छोटा कर दोगे प्रेशर बढ़ेगा लेकिन वॉल्यूम गोइंग टू द ब्रेन विल स्टिल बी लेस, तो हाइपोक्सिया तो अभी भी मेंटेन है। बॉडी बोलती है देखो फालतू का काम नहीं करना, आधा अधूरा काम नहीं करेंगे, पूरा काम करेंगे। पूरा काम क्या है, हम प्रेशर भी बढ़ाएंगे वॉल्यूम भी बढ़ाएंगे। एंड हाउ डू यू अचीव दैट, तो सिस्टोलिक ब्लड प्रेशर बढ़ाने के लिए आई नीड टू इंक्रीज द आउटपुट, ठीक है। तो मेरा गोल ये है कि मुझे कार्डियक आउटपुट इंक्रीज करना है। क्लियर है, आने वाला बॉडी ग्रेट प्लान है, करेगी कैसे। तो बॉडी बोलती है ये तेरा लेफ्ट वेंट्रिकल है, ठीक है। अब लेफ्ट वेंट्रिकल में कॉन्सेप्ट है, इसको बोलते हैं प्रीलोड। व्हाट इज प्रीलोड, इट इज द अमाउंट ऑफ ब्लड अवेलेबल इन द लेफ्ट वेंट्रिकल जस्ट बिफोर द कॉन्ट्रैक्शन। और ये जो अमाउंट ऑफ ब्लड अवेलेबल इन द लेफ्ट वेंट्रिकल जस्ट बिफोर द कॉन्ट्रैक्शन इज व्हाट वी कॉल इट एज प्रीलोड। दिस इज व्हाट वी कॉल इट एज प्रीलोड। फिर बारी आती है आफ्टर लोड के कॉन्सेप्ट के। आफ्टर लोड का कॉन्सेप्ट क्या है, इट इज द अमाउंट ऑफ ब्लड विच इज लेफ्ट बिहाइंड। आफ्टर लोड इज द अमाउंट ऑफ ब्लड that is left behind after the contraction। तो प्रीलोड मतलब पहले कितना था, आफ्टर लोड क्या है कि बाद में कॉन्ट्रैक्शन का कितना बचा, ठीक है। सो दिस इज योर आफ्टर लोड। तो हमको दो चीजें पता लगी, प्रीलोड और आफ्टर लोड। तो अगर आप प्रीलोड को आफ्टर लोड से माइनस करोगे तो आपको पता चला कितना ब्लड बाहर चला गया, राइट। सो दिस इज व्हाट वी कॉल्ड एज कार्डियक आउटपुट और आई कैन से स्ट्रोक वॉल्यूम व्हिच इज प्रीलोड माइनस आफ्टर लोड। कार्डियक आउटपुट पर मिनट मानोगे, स्ट्रोक वॉल्यूम पर कॉन्ट्रैक्शन मान लोगे, ठीक है। सो अगर प्रीलोड में से आफ्टर लोड निकालोगे यू विल टेल द अमाउंट ऑफ ब्लड गोइंग आउट एंड दिस अमाउंट ऑफ ब्लड गोइंग आउट इज नथिंग बट योर कार्डियक आउटपुट। तो अब मुझे कार्डियक आउटपुट बढ़ाना है, ठीक है। इफ आई हैव टू इंक्रीज द कार्डियक आउटपुट आई हैव टू इंक्रीज द प्रीलोड। तो मैं क्या करूंगा, आई विल अलाउ द लेफ्ट वेंट्रिकल टू फिल फॉर लॉन्गर ड्यूरेशन ऑफ टाइम सो दैट आई कैन इंक्रीज द प्रीलोड। अगर आप प्रीलोड इंक्रीज करोगे व्हाट इज गोइंग टू हैपन, इफ यू इंक्रीज द प्रीलोड ऑब्वियसली द कार्डियक आउटपुट इज गोइंग टू इंक्रीज। अगर कार्डियक आउटपुट इंक्रीज करेगा इट इज द अमाउंट ऑफ ब्लड गोइंग इनटू द आयोटा फ्रॉम द हार्ट, so वॉल्यूम ऑफ ब्लड इज इंक्रीजिंग। अगर वॉल्यूम इंक्रीज करेगा ल्यूमन का साइज सेम है तो क्या होगा, इमेजिन दैट द ब्लड दिस इज नाउ एंटरिंग इनटू द आयोटा। ये आपका आयोटा हो गया। अब ये जो ब्लड है which is ejecting is now entering into the aorta, obviously the blood coming into the aorta is now increased क्योंकि कार्डियक आउटपुट इंक्रीज करो ना, तो वॉल्यूम ऑफ ब्लड which is coming into the aorta would increase, जिसकी वजह से aortic pressure क्या होगा, इंक्रीज हो जाएगा। So this increase in cardiac output, this increase in cardiac output is going to increase the aortic pressure and when the aortic pressure increases this is what we call it as hypertension। तो ये पहला फिनोमेना हो गया हाइपरटेंशन का। फिर दूसरा, नाउ आई एम इंक्रीजिंग प्रीलोड, इफ द प्रीलोड हैज टू बी इंक्रीज द टाइम टेकन फॉर द लेफ्ट वेंट्रिकल टू फिल हैज टू इंक्रीज। लेफ्ट वेंट्रिकल को ज्यादा टाइम लगेगा भरने के लिए। अगर टाइम टेकन फॉर लेफ्ट वेंट्रिकल इज मोर, मतलब अगर लेफ्ट वेंट्रिकल को ज़्यादा टाइम लग रहा है भरने के लिए तो पर मिनट कॉन्ट्रैक्शन क्या होगा, मान लो कि पहले 1 मिनट में आपका लेफ्ट वेंट्रिकल 60 टाइम्स कॉन्ट्रैक्ट कर रहा था, अब मैंने क्या किया, फिलिंग टाइम को 1 सेकंड से 2 सेकंड बढ़ा दिया, मतलब एवरी सेकंड आफ्टर 2 सेकंड इट इज कॉन्ट्रैक्टिंग, तो 1 मिनट में कितनी बार कॉन्ट्रैक्ट करेगा, 30 टाइम्स। सो इसकी वजह से क्या हो गया, रेट ऑफ कॉन्ट्रैक्शन इज डिक्रीज, सो दैट इज व्हाट वी कॉल एज हार्ट रेट। सो व्हाट इज गोइंग टू हैपन टू हार्ट रेट, हार्ट रेट विल डिक्रीज, एंड डिक्रीज इन हार्ट रेट इज व्हाट वी कॉल इट एज ब्राडीकार्डिया, and raised ICT will cause pressure on the CP angle जहाँ पे आपका respiratory center है, and that will cause differential stimulus जिसकी वजह से irregular respiratory rate होगा, it's a irregular respiratory rate, and this is what we call as Cushing stride. देखो Cushing stride पूरा लिखने पे कुछ नहीं मिलेगा, but if you explain the Cushing stride, that is where your point is going to lie, ठीक है। सो कुशिंग स्ट्राइड हर उस जगह में मिलेगा जहां पे आपको रेज्ड इंट्राक्रेनियल प्रेशर मिलेगा, क्लियर है। नाउ दिस इज अ वेरी ब्यूटीफुल कॉन्सेप्ट दैट यू नीड टू अंडरस्टैंड, यू कैन नॉट सिंपली मग इट अप बिकॉज इट्स नॉट गोना वर्क इट आउट, ठीक है। कल को जाओगे, इंटर्नशिप करोगे, वार्ड्स में रहोगे, आईसीयू मैनेज करोगे, तो आपको ये चीजें पता होनी चाहिए, एग्जाम तो चलता रहेगा, क्लियर है। क्विक फीडबैक चले आगे, ठीक है। फिर अगर आपसे पूछेगा व्हाट इज द मैनेजमेंट ऑफ द कुशिंग स्ट्राइड, the management of the Cushing stride, I will start the patient on IV mannitol. Start the patient on IV mannitol. Give oxygen. Maintain the systolic blood pressure to be more than or equal to 100 millimeters of mercury. And if required, intubate. Okay. Now, once you have done this, obviously you have certain parameters to maintain, which is called as a goal in the management. What is the goal that you have? The first goal, the intracranial pressure should be maintained less than 20 millimeters of mercury. Second goal is the cerebral perfusion pressure should be maintained at more than or equal to 65 millimeters of mercury. Okay. Then maintain the partial pressure of oxygen to be more than 100 millimeters of mercury. Get your sodium and glucose to be normal. The sodium level has to be maintained at its normal, that is 135 to 145 milli equivalents. And the last one is your glucose. The glucose level has to be maintained between 80 to 180 milligram percent. तो ये goals हैं in the management of your intracranial pressures, ठीक है। So protocol and goals, both of them are clear, and this completes our neurotrauma. जो सवाल हमारे पास पुराने आ रखे हैं, so this concludes that, ठीक है। So now we'll talk about the thoracic trauma. We have two conditions, one is flail chest and another one is pneumothorax. So we'll talk about both of them. So we're talking about pneumothorax. So we have the answer on the traumatic pneumothorax. Now, by the definition, what is pneumothorax? Pneumothorax, it is defined as collection of air between parietal pleura, between the parietal pleura and visceral pleura. It is the collection of air between the parietal pleura and visceral pleura resulting in poor expansion of lung. Resulting in poor expansion of lung is what we call as pneumothorax. As simple as that. ठीक है। अब बारी है कि pneumothorax जो है, it can be of two varieties. One is your open pneumothorax, another is a tension pneumothorax. So we'll classify them accordingly. So we have something called as the tension pneumothorax. And then you have the open pneumothorax. So we have the tension pneumothorax and the open pneumothorax. What is the difference, right? Now you take this as the representation of the thoracic cage. Let's say this is the lung that you have. Let's say this is the right lung that you have. This happens to be the left lung. Right dead in the center, let's say you have the trachea. So you will take this as a representation of the trachea. This is the right main bronchus. This happens to be the left main bronchus, and then it bifurcates. Across. So these are your tracheal rings which are present. This is the carina, that is the junction that is present all across here, right? So this is your tracheobronchial tree that you have. Next comes the pleura. The one that is covering the lung parenchyma is what we call it as the visceral pleura. So this is what we call it as the visceral pleura. So this is the visceral pleura that you have. One that is covering the wall is what we call it as the parietal pleura. So this happens to be the parietal pleura. So try to understand what is a tension in an open pneumothorax. So talk about tension pneumothorax. The injury to the lung occurs within the parenchyma. So there's a parenchymal injury that is going to occur. Usually it can be because of a blunt trauma, anything. There's an injury to the lung parenchyma. Because of this injury, there is breach in the pleura as well. So you see that there will be breach in the visceral pleura as well. So this is the injury that has occurred, and this injury has led to the breach in the pleura. What is going to happen? The air that is going to come out. Let's say the air that is going to come out from here, with every inspiration, the air is going to leak out. As more and more amount of air is going to leak out, this air is going to get accumulated here. Now, as more and more amount of air is going to get accumulated, as more and more amount of air is going to accumulate, it is going to compress the lungs. As more and more amount of air is going to be accumulated, it is now going to compress the lungs. Now, as the lungs are going to get compressed, as the lung is going to get compressed, this is the pleural space that is there, and the pleura is also getting compressed. So whatever is being accumulated is now exerting pressure onto the lungs, not allowing the lung to expand properly. So obviously they will not be able to get enough amount of air or oxygen. Another thing is that you will see the trachea is also going to be pushed. The trachea, which is supposed to be centrally present, under the influence of this pressure, you will now see the trachea deviating to the opposite side. You will notice that the trachea is going to be deviated. You will see the trachea is deviated to the opposite side. So the tracheal deviation that is present, and this is what we call as tension pneumothorax. So what did we understand? That the air leak in the tension pneumothorax is from the parenchyma itself. So the air starts leaving within the parenchyma, gets accumulated within the parietal space, that is the parietal pleura and the visceral pleura, hence resulting in tension pneumothorax. So just for the sake of understanding, if I label it off, this is your parietal pleura, the one that I've given in orange. The green one is what we call it as the visceral pleura. And the accumulated component that you have is of air, right? So parietal pleura, visceral pleura and air, this is what we call it as your tension pneumothorax. Open pneumothorax mein kya hai? Somebody has taken a knife and then stabbed it. Now that stab has caused an entry point here. Let's say ये stab हो गया, यहाँ पे entry बन गई, ठीक है? अच्छा, अब ये जो एंट्री है, इट हैज़ टू बी सिग्निफिकेंट. इतना छोटे मोटे एंट्री से ना न्यूमोथोरैक्स नहीं होता. अगर किसी ने आपको नीडल लिया और प्रिक कर दिया, नीडल से आपको न्यूमोथोरैक्स नहीं होगा. Now the criteria for open pneumothorax to be created, that the size of the wound should be more than or equal to 3 centimeters in diameter or more than or equal to 2/3 of tracheal diameter. इनमें से अगर कोई एक क्राइटेरिया सेटिस्फाई होता है देन इट इज बाउंड टू डेवलप एन ओपन न्यूमोथोरैक्स. ठीक है. अच्छा, so what is going to happen, the air is going to be sucked from the external environment because of the negative pressure. So you have intrathoracic negative pressure, so obviously it is going to pull the air out. Now as the air is going to flow from outside, you will see more and more amount of air is going to get accumulated between the parietal and the visceral pleura. As more and more amount of air is going to get accumulated, same effect that is tension pneumothorax it is going to create. It is now going to compress the lungs. It won't allow the lungs to expand. So it is now filled up with this entire column of air. It is not allowing the lung to get expanded. So because of this, you see now the lung is getting compressed. The pleura remains intact, but the air is coming from the external environment. It is exerting pressure, so obviously the lung remain compressed. So patient will not be able to have an adequate expansion. Same thing, you see the trachea is being pushed onto the other side. You will notice the trachea deviated to the opposite side. You see the trachea is being deviated to that of opposite side, because its trachea deviates to that of opposite side. Okay? So this is the difference between open and a tension pneumothorax. Clear? So the basic concept is, in a tension pneumothorax, the air leaks within the thoracic space or thoracic cavity. In an open pneumothorax, the air is drawn from an external environment, right? So when you talk about the air entry in a tension pneumothorax, here air, it is going to enter between, parietal pleura and visceral pleura from the lungs or the tracheobronchial tree. Whereas in terms of open pneumothorax, air enters, entry of air, that is entry between the parietal and visceral pleura from the external environment. So the air entry between the parietal and the visceral pleura from the external environment is what you see in your open pneumothorax. So we talk about the mode of injury that you talk about it here. Usually the tension pneumothorax, they are associated with blunt trauma. Open pneumothorax, they are associated with penetrating chest injuries. Right? How will they present to you in terms of clinical features? Now, any patient who is suffering from the pneumothorax, or I can say tension or open pneumothorax, they have common findings, right? The first thing, obviously, lung is compressed, patient will have difficulty in breathing, there will be presence of dyspnea. Now, there is only one lung compensating for both the lungs, they will be associated with tachypnea. There is presence of dyspnea, there is tachypnea is there. The patient will have chest congestion because the air is filling up. As see, normally it's a negative pressure. No, when the air starts filling up, it pressurizes positively, right? Hence, the patient will have that compressive chest feeling called as chest congestion. Along with that, so there's dyspnea, there's tachypnea, there's chest congestion. These are the presenting features. When you examine this patient on examination, what do you see? Obviously, all the head and neck veins that are draining into this side of the chest will not be able to drain because of positive pressure. So there will be presence of distended neck veins. There is distended neck veins. Because there is chest congestion and pain, you will do an auscultation. You will see there is absence. There is absence of breath sounds on auscultation. there is absence of breath sounds on auscultation. When you do a percussion, on percussion there is hyper resonant note. There is a hyper resonant node on percussion. Everything that we have told will be present in penetrating chest injuries also, but additionally in penetrating chest injury you will find there is presence of sucking chest wound. Now what is this sucking chest wound? It is the wound from where the air is entering into the thoracic cavity, and this is what we call it as a sucking chest wound is present. This is for penetrating chest injuries. Now how would you like to evaluate? In terms of investigation, tension pneumothorax is a ticking time bomb. So here it is only clinical examination. Here we have to patch the chest wound and send the patient for chest x-ray. Here you can do something called as an E-FAST. That is your extended protocol for your focus assessment with sonography in trauma. Sir, your BLS lectures are better than recorded at MedEd. Aditya Tiwari, I'll take this as, I don't know whether to take it as a positive feedback or a negative feedback. Right, so we have taken all the feedbacks for our MedEd's third version, that is 3.0. It's gonna come out soon. We have heard every single comment that you have made, every single suggestion that you have done. We will incorporate that in our 3.0, and trust me, our 3.0 recording will be on par or better than any other platform that is available. That's a guarantee. Okay, chalo. Now, how would you like to manage? So in terms of management, pneumothorax are taking time bombs, right? In the management, we have emergency management and definitive. So in emergency, what you have to do is needle thoracocentesis. So in needle thoracocentesis, if it is a child, then I will put in the second intercostal space of mid-clavicular line. If it is an adult, for an adult, I will put in the fifth intercostal space of mid-axillary line, right? Sir, अभी तो 2.0 के notes मंगाए बेटा. Okay, notes are going to be abhi recently updated hai, so don't need to worry about it. When you're talking about the re-recordings of the 3.0, which has probably taken another 6 months or so, उसमें देखो notes मोटा मोटा वही रहेगा. There's nothing more drastically changing, but the way of presenting a lecture, क्योंकि पहले version और second version में थोड़ा improvement था, तो we are trying to improve the video quality. ठीक है, डिलीवरी क्वालिटी, सिस्टम, यूसेज ऑफ स्मार्ट बोर्ड, तो ये चीज़ें चेंज होंगी, लेकिन कंटेंट चेंज नहीं होगा. तो ज़्यादा डोंट गेट दैट हेड अप. या पढ़ाना वही बेली से है, वही सैबिस्टिन, द कंटेंट रिमेन्स मोर और लेस द सेम. बदलेगा नहीं, टेंशन नहीं लेना. ठीक है, चलो. नाउ व्हेन यू टॉक अबाउट डेफिनेटिव मैनेजमेंट, when you talk about the definitive management, definitive management would be to put an intercostal drain. That is, ICD has to be put, which is called as the intercostal drain. Normally, अगर आप ICD बोलोगे ना, in child, I'll be preferring an 18 French. In an adult, I would prefer a 28 French. ठीक है? That is standard ICDs that you put. Now, where would you put the ICD? Now, ICD has to be put in something called as the safety triangle. So, if you take, this is the lateral view of the thorax. Okay? And imagine that these are the ribs that we're talking about. Okay? Just for sake of understanding, if I label it 2, 3, 4, 5, 6, 7, 8, right? Now, this is the anterior surface, this is the posterior surface. Anteriorly, there is a muscle that is going to present, and that muscle is going to cover this space. Posteriorly, there is another muscle which is going to cover this space. Anteriorly, the muscle that is covering is your pectoralis major muscle. Posteriorly, the muscle that is covering it is your latissimus dorsi. So anteriorly you have pectoralis major, posteriorly you have the latissimus dorsi, and inferiorly you have the sixth rib. Okay. So there is a small triangle that is formed here. You see between the sixth rib and these two muscles, no, ये छोटा सा triangle बना है और इस triangle के यहाँ पे you will put your ICD. This is what we call it as a safety triangle. ठीक है. So in a safety triangle, if you look at this, this is your mid axillary line. Okay. Now the safety triangle, anteriorly you see it is formed by the pectoralis major muscle. Posteriorly it is formed by the latissimus dorsi muscle. Inferiorly it is formed by sixth rib. And the space in which you're going to put the ICD is going to be your fifth intercostal space of mid axillary line. Now this is what we call it as the safety triangle. This is what we call it as the safety triangle. Okay. So this is where you're going to put the ICD, and this is the definitive management for your pneumothorax. Okay. So we covered our pneumothorax also. The last topic, which is again a short note, it is flail chest. So there are two definitions of flail chest. One is your ATLS and another is Bailey's. It says when more than or equal to 3 continuous ribs fracture at more than or equal to 2 different sites. At 2 different sites. This is a Bailey's definition. ATLS is when more than or equal to 2 continuous ribs fracture at more than or equal to 2 different sites. This is what we call it as your flail chest. Both of them are acceptable definitions, but if you say what is a better one, then the answer is going to be more than or equal to 3 continuous ribs fractured 2 different sites, right? Now for a flail chest, what is the mode of injury? The mode of injury for a flail chest, it is going to be blunt trauma thorax. So let's understand the pathophysiology. So when you look at the pathophysiology, so this is the mode of injury. This happens to be the pathophysiology. So look at the pathophysiology. Let's say this happens to be the sternum. I'm giving you a lateral view. And let this happens to be the vertebra. Let's say this is the thoracic vertebra that is present here. I'm giving a lateral view just for the sake of understanding, right? Now let's say these are the ribs which are going to be attached. So these are the various ribs. Anteriorly it is attached to sternum, posteriorly it is attached to vertebra. Now right in this dead center you have your lung. Let's say this is the lung that is present. Between the two ribs you have your intercostal muscle. So this is the intercostal muscles that are present. This is the intercostal muscle that is present. So making this entire ribs to act as one single unit. They're making to act this one entire rib cage to act as one single unit. Right. Now, when we say that the patient is having a flail chest, we have just discussed where the patient is going to have 3 continuous ribs fracture at more than or equal to 2 different sites on the same rib. So the 3 continuous ribs fracture right. The 3 continuous ribs fracture at more than or equal to 2 different sites on the same rib. So let's say the fracture number 1 is here, the fracture number 2 is here, and the fracture number 3. The 3 continuous ribs were fractured. Now you see, when you look at the fractured segment, this is one fractured rib. There's another fractured rib here. And there's another fractured rib here. So there are 3 continuous ribs which are fractured at 2 different sites on the same rib. So what has happened is you have found that this fragment of the ribs, which are neither attached to that of the vertebra, not to the vertebra, not to the sternum, it is what we call it as the flail rib segment. It is called as a flail rib segments. This is what we call as a flail rib segments. ठीक है, ये जो flail rib segments है ये neither vertebra पे attached not sternum पे attached, free flutter, इसलिए इसको बोलते हैं flail segment. Now because of this the patient will develop something called as the paradoxical breathing. Now what is this paradoxical breathing is? Normally during inspiration we expect the ribs to move away from the lungs, but in this flail chest during inspiration flail segment moves closer to the lung and compresses it. It moves closer to the lung and compresses lung, and that is what the problem occurs in your flail chest. Okay. Now when you talk about the clinical presentation of the flail chest, because there is increased work for breathing, to overcome this paradox, you have to use axillary muscle. There is increased work for breathing. That means there is usage of accessory muscles of breathing. There will be usage of axillary muscles of breathing. Now axillary muscles are skeletal muscles. They get fatigued, and because of fatigue it will result in painful breathing. Now because of painful breathing, it will result in eventually patient will have dyspnea, that is difficulty in breathing. There will be tachypnea, and there will be shallow breathing. If it is unaddressed, patient will result or lead into respiratory failure. Goes into respiratory failure. Now, when you talk about what is the investigations that you can do for flail chest, single best is going to be X-ray, that is your chest X-ray. Management for flail chest is adequate analgesia. Now, how do you deliver this adequate analgesia? It is better to give with thoracic epidural analgesia. Epidural analgesia. If patient develops respiratory failure, then it is better to intubate and give IPPV. IPPV is your intermittent. It is intermittent positive pressure ventilation. It is your intermittent positive pressure ventilation, right? So this is what you will do in the management of flail chest. Okay? So this concludes every single topic that is there for our Farre series. So this has been our last topic. We have completed the flail chest. We have done the traumatic pneumothorax. So this is all that you should know in the context of trauma as well. These were your previous exam questions which we tried to discuss. Okay? So all the best for your university exams. If you have any questions, any queries, do write us. Do send us the queries. We are available on Telegram. We are available on Instagram as well. If you want to reach out directly, you also know where to get this. You can follow me on my Instagram. That is your surgery guy. This is by my name, Dr. Sandeep Seeram Reddy. Any questions, any queries, do reach us out. Okay? Thank you so much for joining, and all the best for your exams. Thank you.